Namaskar, dear viewers. Welcome to today's session of Young India Intensivist webinars. And today is our international faculty webinar seminar, and it's a great honor and pleasure for me to have a very special guest, Dr. ELIAS Kassis. Sir is assistant professor at Harvard Medical School and BETH ISRAEL Deaconess Center. He's the director for respiratory care and is involved in a lot of research work as well. And his area of research is mechanical ventilation, ARDS, sedation, neuromuscular blockers, mainly topics dealing with respiratory critical care. And he's associate professor, like I said, of medicine and anesthesia. And he's also been distinguished with the American Society Unrestricted Critical Care Award 2023 Teacher of the Year. So indeed, it's a pleasure and honor to have you, Dr. Cassis, with us. And we really thank you for your time. It's over to you.
Thank you so much for that wonderful introduction. It's wonderful to be on here. Let me share my screen now and move over to my slides. All right. Can you see my slides?
Yes, sir. Dr. Cassis, we can see.
Okay, very good. All right, so in that case, I'll get started. So today I'm gonna talk about sedation and neuromuscular blockade, and kind of take a look at kind of a particular angle that I'm interested in the future of these two important treatments in our critically ill patients who are mechanically ventilated. This is my grant funding. I've got a number of grants from the NIH and then some industry grants from Draeger and Hamilton as well, which are ventilator companies that we work with closely. So why don't we get it started with a quick case as a jumping off point for our further discussion. All right. So here we have a patient, 48-year-old patient with COVID and ARDS. They're already deeply sedated with a RASS score of -5. And as you can see, they're pretty dysynchronous despite the high levels of sedation. And so I think this is a common question that many clinicians come up against, is what do we do in a deeply sedated patient who is still dysynchronous? What do we do with sedation, with the ventilator, et cetera? And indeed, I think oftentimes we feel like sedation is a bit of a tug of war between two competing sides, really balancing the potential benefits from sedation and neuromuscular blockade, protecting the lungs when patients are very sick, versus the harm that you might directly get from sedation. So on one hand, the use of sedation and neuromuscular blockade may be very helpful. It may prevent ventilator-induced lung injury and as well as self-inflicted lung injury and allow for tolerance of lung protective ventilation. However, conversely, sedation and neuromuscular blockade may be directly harmful. They may cause diaphragm injury and weakness. They may prolong intubation. They've been associated even with increased death, myopathy, delirium, and kind of myriad other things, including ventilator-associated pneumonias and anything that's associated with prolonged intubation. And so it's this really kind of this tug of war between the two sides of finding the benefit in some patients and balancing that with the harm in other patients. And I do think that it is increasingly evident that deeper sedation may cause or be associated with harm. And this is work from my group from several years ago, looking at sort of the relative depth of sedation relative to the probability of survival. On the left, you can see that the light sedation group has improved probability of survival versus the deep sedation group. And this was from a mediation analysis that was performed. And then you can see that the hazard ratio for in-hospital mortality was much higher as the depth of sedation increased, which you can see on the right. And this is retrospective data, but this has been repeated in many other studies by many other groups, and it's really consistent across studies and across cohorts of patients internationally. And so I think it's hard to ignore the potential risk that we have from high levels of sedation in our patients. And I think what happened, what we saw in COVID, this is again from our group as well, is the burden of sedation really increased in COVID and actually has kind of lingered a little bit after COVID too. Maybe not quite as bad as during COVID itself, but here you can see that the dark blue is is what we are called coma. So that's a very deep level of sedation, and you can see how much that increased relative to the sort of lighter levels of sedation in the patients. And then how this was associated with increased death as well, potentially. Obviously, it's hard to attribute direct causality from the sedation, but again, I think it raises these questions which are important to consider going forward. Is the very things we use to allow for tolerance of lung protective ventilation and tolerance of being ventilated at all actually worsening some of the outcomes for our patients? And so rather than thinking of this as just a sort of standard tug of war between these two, what our group and some others have been proposing is that we can probably start thinking about bridging the gap between these two sides and finding a balance between it. And this balance, we believe, is in the form of what we call lung protective sedation. And so rather than creating sort of one-size-fits-all approaches, we believe that maybe a targeted sedation practice with personalized goals, defining specific sedation effects, looking at harmful versus tolerable levels of patient effort, as well as harmful versus tolerable levels of dysynchrony, and then coupling this with improved monitoring of patients may allow for a balance between these two to be better. And so what do I mean by this exactly? What do I mean by personalized goals for sedation? Well, obviously, we have patients who are at risk for ventilator-induced lung injury from atelectasis trauma with a cyclic and opening closing of the lungs and collapse, as well as barotrauma and volutrauma, which I like to call overdistension injury. And this is one of the major things we try to avoid in our patients with ARDS. And so in the case of very sick patients, lung protective sedation would equal assuring tolerance of these uncomfortable settings. And then many of you may be familiar with this concept of self-inflicted lung injury, which is a growing understanding of the potential risk for patients who are spontaneously breathing. And the idea behind this is that the patient's own breathing activities may cause additional mechanical injury, kind of similar but very distinctive from ventilator-induced lung injury, from typical VILI. And so the idea behind this is that the actual patient's efforts, their diaphragm contractions, create negative swings in pleural pressure, which are not uniformly transmitted throughout the lung. There's a sort of pressure concentrated in the dependent lung regions because of the solid-like behavior of the lung when it's injured. And this creates unequal transpulmonary pressure swings across the lung tissue, which may further magnify the lung injury locally. Additionally, there's a feature called Pendeluft, which is movement of air from within the lungs, separate from the bulk movement of air in and out of the lungs. And this may locally worsen stress and strain in those dependent regions in particular. And so self-inflicted lung injury, we think, is very important to limit in some cases, particularly the very sickest patients. So in some cases, lung protective sedation would be the removal of spontaneous breathing. But I also think, importantly, it's not always the removal of spontaneous breathing. It's really just reduction of the injurious level of effort, and actually, in some cases, allowing spontaneous breathing, which we'll talk about more going forward. Additionally, dysynchrony is gaining a lot of attention. It still remains, I think, a bit of an unknown for a lot of clinicians, and our research is still lagging behind on it. However, what is clear is that dysynchrony, in many cases, may be harmful or associated with harm. It's been associated with increased ICU stay and mortality. It may be a direct mechanism of lung injury with large transpulmonary pressure swings and tidal volumes. It may be associated with hypoxemia, increased muscle work, and discomfort as well. And in some cases, lung protective sedation, as we'll talk about, is the removal of injurious dysynchrony. But in other cases, it may just be attenuation of it as well, and tolerance of some forms. And that's why we say specifically removal of injurious forms, because not all forms of dysynchrony are injurious. And then finally, all of these forms of mechanical injury, self-inflicted lung injury, ventilator-induced lung injury, result in biotrauma. And when I say biotrauma, I mean the eventual local effect of all that mechanical injury, as well as any direct injury that's already occurring in the lungs from the pneumonia itself, potentially, for example, results in accumulation of all of these inflammatory cytokines, as well as macrophages and other cells that are localizing within the lungs that are attempting to actually counter the infection and the inflammation, but may inadvertently cause additional injury. And so what we think is that lung protective sedation is obviously the reduction of mechanical trauma, which may decrease biotrauma, but it may also be a direct reduction in local inflammation through the activities of the sedative itself. So there may be direct sedative effects on the biotrauma as well, which we'll talk about. And so I think the first thing we talked about is what is the actual effect of sedation on effort and dysynchrony on our patients. And it's very clear that sedatives have a relationship with respiratory drive. Sedatives and analgesics clearly result in respiratory depression. I think the thing that's important, though, is that these effects are actually quite widely variable and difficult to predict for our patients. For example, opiates can result in actually sometimes larger tidal volumes, which I'm sure you've all seen in patients with opiate overdoses. They may have apnea, but then with sort of large gasping breaths. And notably, the opiate breathing pattern is very different from the breathing pattern that we desire in our sickest patients with ARDS, right? So this apneic ventilation with large breaths is very different from the fast respiratory rate and low tidal volumes that we typically apply in our patients with ARDS. And I think increasingly what's also evident is that our measures of sedation depth are quite different from our measurements of patient effort and dysynchrony. So this was a study done by my friend Jeremy Beitler, who used to be at Columbia, now at NYU. They enrolled 56 patients and did 197 bedside observations, and they found that there was no association between respiratory drive and sedation depth based on RASS score. In fact, they found that the highest P0.1 values, the P0.1 is the pressure that is driven by the patient in the first 100 milliseconds of an occlusion, but is also easily measured non-invasively on many ventilators on breath-by-breath basis. They found that this P0.1 value, which is a measure of respiratory drive, was actually oftentimes the highest in patients with very, very low RASS scores from -3 to -5. So the folks with the deepest level of sedation sometimes had the highest measured levels of respiratory drive. Additionally, what's important is understanding that increased sedation doesn't always get rid of dysynchrony. And dysynchrony itself, I think, is oftentimes people treat it with sedation, but some forms of dysynchrony are actually unmasked or worsened by deeper levels of sedation. In particular, ineffective efforts or mistriggering. So this is from DeWitt from several years ago, looking at a small number of patients, just showing that as the RASS score dropped, the ineffective effort index, the index of mistriggering increased. In particular, though, a form of dysynchrony that our group has been particularly interested in, this is from several years ago that I published in the Blue Journal, looking at reverse triggering, which is a form of dysynchrony which actually may be unmasked by deeper levels of sedation as well. It's a neuromechanical coupling, oftentimes called a reflex, but it's not a true reflex, but it's a coupling of two oscillatory systems that couple together. And here you can see patients are having coupling of the diaphragm contraction that are coupled to the vent-delivered breath. And on the top here, under PES, that's esophageal pressure, which is a technique that we use to actually get a better understanding of what's happening with the patient's breathing. And you can see that these drops in esophageal pressure indicate diaphragm contractions that are localized after the ventilator delivered breath. So the patients are not triggering the breaths themselves. These are ventilator triggered breaths followed by a patient effort. And you can see when during inspiratory and expiratory holds, the patient efforts actually stop. And that shows very tight coupling, as you can see. And this is due to entrainment of the patient's own respiratory efforts with an external stimulus, which very clearly shows that this is a form of reverse triggering. Reverse triggering has a number of different effects during the inspiratory phase. It's very common. It can cause injury from increased tidal volumes and breath stacking, increasing lung stress as well. And I think importantly, this idea of asynchrony as being a potential harm has kind of emerged as well from this. And this is from Louis Blanc, who's a intensivist in outside of Barcelona in Spain, in collaboration with the Better Care System, which is this really nice way of looking at a large amount of data, of waveform data. They were able to analyze 50 patients with over 8 million breaths, and they looked at an asynchrony index, which was a combination of ineffective efforts, double triggering, aborted inspiration, short and long cycling. They did find that the ineffective efforts are the most common, and they actually found that the higher asynchrony index was associated with worsened outcomes in patients. And this has been repeated by several other groups as well. This was another study by Vaporiti from a few years ago in 2017, looking at 110 patients, and they found an ineffective trigger index of over 10% was associated with worsened outcomes overall. And they looked at clusters of efforts as well, which were associated with prolonged duration, mechanical ventilation, mortality. And in this nice meta-analysis looking at all the different studies that have looked at dysynchrony, they found that an asynchrony index or an ineffective trigger index of greater than 10% was actually associated with worsened outcomes, both mortality as well as other outcomes. I think what's important, though, and really it hasn't been addressed in any of these, is that the harm from the dysynchrony that they show here is probably actually not harm from the dysynchrony itself, but harm from the sedation that is used in the patients as well. Either the sedation that's unmasking the dysynchrony, for example, ineffective triggering is probably not a form of dysynchrony that directly causes harm for the patient. It maybe is more a marker of patients who are more deeply sedated. And then additionally, in patients who are having some of the forms of dysynchrony that may be associated with harm, maybe it's just actually the clinicians who are trying to treat the dysynchrony with increased sedation that is driving the signal as well. And this remains a big question in the field right now and requires further investigation. But my personal view is that actually many forms of dysynchrony are more of a nuisance, and actually just showing the link here between harm and worsened outcomes and dysynchrony is really from the pathway of increased sedation. So the question then emerges, are there specific benefits of different sedatives themselves? And this is a hard one to answer with, again, because we don't have the data to clearly define which are the best agents to actually use. And so in particular, looking at, so what I care about oftentimes most is using our analgesics and our sedatives for patient synchrony. This was a nice study by Daharo et al. From 2019, looking at 79 patients with over 14 million breaths, looking at what they called sedative equivalents, where they combined propofol, midazolam, and lorazepam, as well as opioid equivalents, looking at morphine and fentanyl. And in their study, they found that opioids were the most effective at suppressing asynchrony, and that sedatives, whether alone or combined with opiates, did not result in better patient-ventilator interaction than opiates alone. The one counter to that was that higher sedative doses administered alone were associated with less double cycling as a form of dysynchrony. I think a lot of people are increasingly using dexmedetomidine or Precedex, which is a nice agent. It has less respiratory suppression, so we particularly use it in patients that we're trying to wean and get them sort of spontaneously breathing on their own. This was a study from 2016 looking at 20 difficult to wean patients, and the patients were randomized to receive either sedation with dexmedetomidine or propofol. They were maintained at a similar level of sedation with a RASS score between +1 and -2. And then they looked at the asynchrony index at various time points at baseline and then up to 24 hours. And they found that the asynchrony index was statistically significantly lower with dexmedetomidine than with propofol alone. Some of you may be familiar with the SPICE-3 trial, which was a trial that looked at Precedex more routinely. They didn't find an overall difference in mortality or clinical benefit with dexmedetomidine, but although subsequent reanalysis suggested potential harm in younger patients and benefit in older patients with dexmedetomidine. But that's a reanalysis and requires additional investigation. However, I do think that in certain populations, dexmedetomidine might be a very good alternative to propofol and some of our standard sedatives and analgesics that we use. One agent that we are increasingly interested in is the use of ketamine. Ketamine, as we know, it has commonly used for induction as well as for conscious sedation in patients undergoing short procedures. But it's also something that we can use in our mechanically ventilated patients. I should have actually corrected this. Is no longer under review. It's actually been published now. So I apologize for that I forgot to correct that sort of bottom little marker. But this is work that we did ourselves, looking at ketamine in a number of mechanically ventilated patients. And we found that ketamine actually decreased the work of breathing with increasing doses. In particular, decreased the resistive work at high dose ketamine. And this is in agreement with prior work that has suggested that ketamine may have direct impact on the airways themselves. And so maybe this is a particularly good agent to be using in certain forms of mechanical ventilation, folks with higher resistance and airway disease, such as COPD and asthma in particular, although further investigation is certainly needed on that. Ketamine in some patients can have more negative consequences, but in general, it seems to be very well tolerated. One particular avenue that I've been very interested in is the use of inhaled anesthetics, taking some of the work, the traditional approach in the OR, and then applying it in the ICU. There's a lot of preclinical animal data and small human studies which suggested that there may be pretty potent anti-inflammatory effects from volatile anesthetics. May reduce neutrophil migration, limit the release of inflammatory cytokines, may sort of impact the mobilization of white blood cells to the pulmonary space, as well as alveolar macrophages and alveolar endothelial cells, and may be particularly beneficial in patients with sepsis and ventilator-induced lung injury and other forms of disease. The initial work on this actually was pretty encouraging. This was a retrospective study from 200 SICU patients who were sedated for more than 4 days, and actually this was a group who received isoflurane versus more traditional approaches. They found that those receiving isoflurane were at a lower risk of death during their hospital stay, as you can see here on the graph on the right. And then some preliminary work in patients with ARDS. This was by Jabedan. This was published in the Blue Journal in 2016. They randomized 50 patients with a PDAF of 100 to 200 and looked at sevoflurane versus midazolam. And they found in this small study that sevo was associated with better oxygenation. It reduced some inflammatory biomarkers like S-RAGE, and there was no differences in renal function, pressors, et cetera. And there was a trend towards improved duration of mechanical ventilation and length of stay. As I'm sure maybe some of you saw recently, this was recently published in the last couple months. This was essentially a follow-up to the study. Same author, Jabedan, as well, did this one. And this was actually quite disappointing for those that were really interested in seeing inhaled anesthetics potentially take off. This was a much larger study, enrolling 346 patients in the sevo group and 341 in the propofol group, and then following them. And as you can clearly see here, there's a higher incidence of death with the sevoflurane group, which was statistically significant, as well as higher incidence of other forms of harm from sevo as well. So the question is this the death of the use of inhaled anesthetics in the ICU? And the answer is probably not, because exactly at the same time, and we don't have the data on this yet published, but this is a sevoflurane study. Actually, our group at BETH ISRAEL, in collaboration with some folks internationally, have simultaneously been doing an isoflurane study. And that study actually is completed, and I won't go into the details of that, but the preliminary data is actually much more encouraging. than in SIVO. And SIVO and ISO are very different agents that have different effects. So SIVO certainly doesn't seem to be helpful. In fact, may be very injurious. But the use of inhaled anesthetics is certainly not dead. And you guys can look for the upcoming publication on the isoflurane study, which was recently completed. The study was called Inspire study. But I don't have any data to show you here because it's too preliminary for us to share that with the general public. Additionally, I think this is a big question is what do we do with neuromuscular blockade? And neuromuscular blockade practices, I think, have evolved over the years. And this is the ACURYSYS trial. And this was a French study, but by Papazian. They enrolled patients with moderate to severe ARDS with a PDEF less than 150. They looked at 90-day mortality. Here you can see they compared the cisatracurium group with a placebo control group that was deeply sedated. And they actually found that there was improved 90-day mortality in the cisatracurium group. As you can see, the separation of the groups was a little bit unusual and was one of the reasons why people questioned the findings here initially. You can see that the two groups actually have quite a lot of overlap early in the disease course until about 20 days when the separation starts to occur in mortality. And why that delay in separation occurs is a little bit unusual considering the treatment was actually quite early on with neuromuscular blockade. They found that the benefit in particular was with patients that were sicker with a PDEF of less than 120. They found that there's increase in pneumothorax in the placebo group as well. There was actually no difference in ICU required paresis, so it seemed that it was well tolerated in terms of the question of muscle injury. And then it was also associated with increased vent-free days and days without organ failure as well. So after this in 2010, I'd say this became a relative standard practice across the country and internationally to apply neuromuscular blockade in patients who have moderate to severe ARDS. So this study was the ROSE study, which was repeated and published a couple of years ago in 2018 it was. They enrolled a similar population of patients and enrolled a much larger cohort. So they looked at patients with moderate to severe ARDS as well and enrolled predominantly in North America and in American, US and Canadian centers. They compared the cisatracurium group to a low sedation control group, which is a little bit distinctively different from the ACURYSYS trial. And as you can see here on the right, the upper line is the survival curves, showing that the probability of surviving was the same in the intervention group versus the control group. And then the group that was discharged home is on the bottom in the red and blue, and it shows that these were also relatively similar between the groups. And so the question is why were these big differences between the ROSE trial and the ACURYSYS trial? One potential is that the ACURYSYS trial was just a little bit of a different population of patients. It was a single center versus this larger multi-center study, and so that there may be some more individual effects that were averaged out across the population when looking at a larger group of patients in a sort of different group. The other possibility is that the patients themselves in the control group were a little bit different. And so if you look at the ACURYSYS trial, the patients in the control arm here, remember, had a deep sedation strategy. And so if we attribute deep sedation potentially with potential harm in some cases, as we've talked about already today, then maybe you're balancing out the effects in some cases between those two groups, and you're actually showing that the that the worsened survival in that group is due to the sedation, and they were actually able to unmask some of the benefit in the cisatracurium group because of that. Whereas in the Rose study, because the control group had a light sedation group, maybe you're actually condensing the potential benefit from the cisatracurium in the group of patients that may have otherwise benefited if the control arm was a deep sedation strategy. I think what's important, though, is that both of these studies didn't look at all at baseline synchrony or patient efforts as part of their inclusion and exclusion criteria. And we think this is very important because even though we certainly don't, we use this data to suggest that not everybody needs to be paralyzed reflexively, we still use, and many centers still do, as we've seen in multiple studies, that neuromuscular blockade is still very commonly applied internationally. But how it's applied probably has evolved and maybe is only being applied or less or more likely to be applied in patients who are very, very sick and who have dysynchrony and or high levels of patient effort. But that wasn't in any way studied by these two studies. And so right now we're left with a big question about how should we best use neuromuscular blockade and what is the future of its use. I think it's important to not just throw away neuromuscular blockade, because I do think that there's still some potential mechanisms by which it might be beneficial. There's some evidence that it may directly affect anti-inflammatory cascades. It may decrease oxygen consumption. It may obviously remove spontaneous breathing efforts and dysynchrony, as we just talked about. In some cases, may decrease hemodynamic compromise from intrathoracic pressure fluctuations. May improve transpulmonary pressures and homogeneous regional ventilation in some cases. And then it may also improve lung recruitment by removal of expiratory efforts as well. And then on the right here, I just want to kind of highlight some of our own work. This was actually some really cool work that we did that we published a couple years ago. And this is looking at a technique called incremental interventions. And incremental interventions basically looks at what is the average propensity across a population to initiate a treatment. And in this case, you can see on the x-axis, the propensity of 1 is sort of usual care. As my propensity increases to 2 to 3 to 4 to 5, that increases my propensity to apply a certain treatment. And as I decrease my propensity from 1 down to 0.8, 0.6, 0.4, 0.2, that's decreasing my propensity. And so what we do is we actually use highly variable time, granular time varying data to actually simulate what would happen to various outcomes under a variety of different disease states, as well as with changing the overall propensity to initiate an intervention. And why this intervention, this technique is so powerful also is that it only really substantially increases the propensity in patients who have a high likelihood at baseline of actually receiving it. So if I'm increasing my propensity by 5-fold, but my baseline propensity is very, very, very low, then my even under circumstances where my propensity is increased, it's really very minimally impacting my overall propensity to add an intervention. Whereas in the patients that are most likely to already be in the group that has a sort of relatively higher propensity at baseline, then you can really see much more substantial changes in the propensity. The other thing that is great about this that you can see is that if you think about a randomized controlled trial, the extreme versions of very, very high propensity and very, very low propensity kind of mirror the two treatment strategies, the control group where no one gets it or the intervention group where everybody gets it regardless. And you can see here that the mortality effect is actually a U-shaped curve. And there was worsened mortality at very low propensity to initiate and very high propensity, with the sweet spot being somewhere close to what is typically being done, but maybe actually with a slightly lower propensity. And why this is exciting is that this tells us that there's probably individual treatment effects that are causing this. And that not only is neuromuscular blockade potentially beneficial in some ways and harmful in others, but there's probably specific groups and strategies that actually can optimize the use of it across populations. And indeed, we extrapolated this a little further, and we were able to show that a slight decrease in propensity improves ventilator-free days and decreases your mortality slightly in this at overall population of patients. And so this is kind of exciting way of analyzing, and we're following this up with some more advanced techniques like emulated target trials as well, using some of the same data. And so I think the next thing I wanted to talk about too, and we can leave some time for some discussion at the end too, is how we monitor sedation. In particular, maybe even better, how we monitor breathing patterns as an extrapolation of how we monitor sedation. And so I think right now, our relationship with sedation is fairly rudimentary, right? We have a saying, which I'm not sure is common in India, but when all you have is a hammer, every problem looks like a nail. And I think that's oftentimes the way that we approach sedation strategies on the ventilator. That's because our markers of sedation are pretty rudimentary and poor. We have the Richmond Agitation Scale, the RASS score. We have the Riker score. There's several others that are commonly used across the globe. But these are all very, very bad at looking at patient-ventilator interaction. The RASS score gives a +2 if there's quote-unquote obvious fighting with the ventilator, but there's really no other markers that are scoring for ventilator synchrony or spontaneous breathing efforts. And this is even more limited with the SAS score, the Riker score. There's nothing at all that indicates a link between sedation and ventilator synchrony. And to be frank, this is one of the primary reasons why we use sedation in our ventilated patients, is to allow for tolerance of the ventilator. So why are our scores that we use focusing on depth of sedation alone and not on the interaction with the ventilator? I would much prefer to have a patient who's sedated to a low level of sedation, but who's synchronous on the ventilator, than a patient who's a RAS -5 or a SAS of 1, but who's very dysynchronous, right? And so we're kind of linking these two things together, which shouldn't be linked. So, we postulate, and others have agreed with this, that the RAS and the SAS are just not ideal scores to be using to assure tolerance on the ventilator and assure synchrony. And the other issue with this is that different sedatives have widely variable effects on respiratory drive despite similar RAS scores. And so what's clear is that sedation does not equal synchrony, and we need to change our approach at the bedside to actually link these two better together. And so one approach which we understand is not generalizable and globally going to be accepted because it involves using esophageal mannometry. However, we think this has become our standard approach at BETH ISRAEL in our sickest patients who have esophageal balloons as part of routine clinical care. On the left here, this is a complicated diagram. This is called the Campbell diagram, which is a basic physiology diagram showing the overlay of the relaxed chest wall compliance curve with the elastic recoil pressure curve of the lung. On the y-axis, we have the lung volume, and on the x-axis, we have the pleural pressure. And what's cool about this is you can see the relaxed chest wall line here on the left within the range of typical ventilation is very linear. And on the ventilator, we actually have the ability to titrate our sedation and our neuromuscular blockade both to a fully passive chest wall. And so as you can see on the two, sorry, I just wanted to get them playing. Not playing for some reason. Here we go. You can see here that in the center video, you have a patient where you see subtle patient inspiratory and expiratory activity, particular expiratory activity, where you see the deviations from the esophageal pressure curve. Whereas on the right, you can see that the patient is fully passive. where the inflation and deflation both fall along the relaxed chest wall compliance curve. And so rather than using a BIS monitor or a train of four, which are measuring sort of additional things that aren't related to the respiratory mechanics themselves, you can directly measure how passive a patient is on the ventilator. And again, this is probably not generalizable to across the globe, because esophageal manometry is a relatively niche approach. But the idea, I think, holds that we maybe should be using measures of physiologic synchrony with the ventilator instead of some of the other scores that we use. And so this is some work that we've been doing, looking at this is sort of, we think that we can create this almost a fingerprint, if you will, of different breathing patterns. I won't go into too much detail about this because this is a whole other talk and discussion. But this panel of 9 breaths shows different breathing patterns, looking at it through this kind of fingerprint, the camel diagram approach, where you can almost start to get an understanding what a breathing pattern is with a unique visual description of what it is. But what's nice about this approach that we've been using to titrate to the passive chest wall is this doesn't really take actually a ton of education about those complex breathing patterns. Instead, you just have to be able to recognize what's passive. And passive is very easy because it's a straight line up and down, as you can see. And so here's a patient who's in panel A, very active inspiratory and expiratory breathing activity with very large tidal volumes and lots of lung stress. The sedation is increased, and this patient still has some breathing activity that's persistent, but it's decreased overall. And then eventually they get neuromuscular blockade. You can see how they become fully passive, and they're fully synchronous. And this is a way of really assuring synchrony in our sickest of patients, but again, using something that's sort of easily titratable and monitorable at the bedside. And just showing you, here's a patient, again, another example of this. Patient is having breath stacking dysynchrony. The patient has increasing sedation levels. We're titrating it to the ventilator. And as we increase the sedation further, the patient becomes more and more passive. Here you can see that there's not fully passive, though, based upon on the bottom right, you can see this sort of a zoom in of the Campbell diagram. And then eventually they become fully passive as we increase the sedation further. The other thing that we're developing is the use of technology to help with assessment of synchrony. And so we have been developing automation software, which actually automates the detection of different forms of dysynchrony. Here is sort of a screenshot of the software we've developed, and you can see that it's labeling RT as reverse triggering, DT is double triggering, BS is breath stacking. So it's finding the episodes of reverse triggering as well as episodes of breath stacking and double triggering. We're training it to identify it with really good sensitivity, with a really good positive predictive value and an F1 score. And then we're taking it even further and using artificial intelligence and machine learning, using principal component analysis, looking at clusters of phenotypes of breathing patterns to help recognize. And this is just showing sort of the clusters of different breathing patterns sort of by multi-component tensor analysis here, which you can see here. And this is a cool future direction of using technology to help guide our decision making. Again, I think I was talking to Tapesh at the beginning. Technology is both, I think, a double-edged sword in a lot of ways. I think there's fear that it may take over some of our work, but I think I'm more of a glass half full person when it comes to technology, and I think that there's some risk for some of the bad things with it. But in general, it's going to allow us to better recognize disease. It's going to be a nice assistant, but it's never going to take away our role in the ICU in particular, taking care of patients and then synthesizing all of this complex data together to create decisions for our patients. But I do see a role in particular with helping complex waveforms and ventilator management, letting us know about some of the disease states and as they evolve. So back to our patient. This was a patient, again, deeply sedated. We can see, maybe some of you were savvy in the audience, you noticed that the patient was having reverse triggering with and without breath stacking, having both And so this was a patient that we ended up lightening the sedation and the reverse triggering improved. And then we're able to actually start weaning the patient relatively quickly thereafter. And so when I see the future of this, this lung and diaphragmatic protective sedation, which I really think is the way we need to be thinking about how we sedate patients going forward, is really getting first a better understanding of the specific sedatives and the analgesics that we use on breathing patterns, because we use a number of different drugs interchangeably, and they may have quite different effects with each other. And this requires more research. So I wish I could give you an answer today about what the best strategy is. We don't know yet. And this requires more investigation. We also need to have a better understanding on which breathing patterns are actually harmful versus benign. There's been a really big important increase in focus on dysynchrony, but this again also is a bit of a double-edged sword. Unless we know specifically which forms of dysynchrony are actually harmful versus simply just a nuisance or benign, we may inadvertently actually be over treating some forms that don't need it. And so we really need to have a better understanding about in whom and what types of breathing patterns are actually tolerable. We also need to monitor sedation better to target lung protection itself and not the sedation level. So I think we need to start developing new forms of metrics to be using instead of RASS and SAS scores. And this involves assuring fully passive breathing in the sickest of our patients, using sedatives to optimize and remove dysynchrony in some patients or simply attenuate it, and then target safe levels of effort when allowing spontaneous breathing. And really overall to try to goal to minimize sedation to the lowest safe levels for patients, which I think is really an important strategy that's needed going forward. Additionally, I do think that there probably still is a future use of some of these non-standard ICU sedatives, including ketamine, and despite the disappointing sevoflurane study in JAMA recently, I do think there could still be a role in a subset of patients with inhaled anesthetics, but I think further research is required for that. And then really get sort of balancing this idea of lung versus diaphragm protection. We need more earlier and more consistent sedation reduction trials, which are still not being applied consistently across the globe. We need to transition to spontaneous breathing as early as is safe, and then maybe even consider diaphragm training in some cases for patients. So I just wanted to acknowledge some of my collaborators and colleagues, Danny Talmore, who's the chair of the anesthesia department, and Steve Loring, who was an amazing physiologist and my first mentor here at Beth Israel, Brian O'Gara, who led the INSPIRE study and some of the inhaled anesthetic works that's being done here, Valerie, who runs our lab, Taylor, who's Taylor Thompson, who ran ARDSNet, who's a mentor of mine for many years when I was a trainee, and then Max, who is a close colleague that I work closely with on a number of projects as well. And I just wanted to say thank you so much for the time, and I wanted to leave a little bit of time for any questions or discussion too. The right is my hospital, and the left is where I live. You can see I live outside of the city and the countryside, which is very nice. And this is the fall foliage that we get, which is very beautiful. So thank you again for your time. And if I'd love to take any questions that might be, if we have time with the audience.
Thanks, Dr. Cassis. It's a pleasure listening to that. A wonderful review and what we should be doing in the near future. Lovely. So, sir, the audience, please, if you have any questions, kindly type them. Meanwhile, sir, I can just put up a few points for discussion, which would be of interest to everybody. So, you mentioned reverse triggering, sir. Is there a best way to treat reverse triggering, or do you try different strategies? So, you can just throw some light on that.
Yeah. So reverse triggering is a form of dysynchrony which is really recently gaining a lot of attention. Reverse triggering, unfortunately, I think comes in many different phenotypes itself, actually. And because of that, the treatment may not be a one-size-fits-all approach. Some of the work that I've been doing actually is looking at phenotypes of reverse triggering. There are forms that happen very early in the inspiratory phase, which only involve lung inflation, and then others that are happening later in the deflation phase, and the effects, the negative or positive effects may be quite variable between those. So the first thing is not all reverse triggering probably needs to be intervened upon. Some forms of reverse triggering probably are more similar to inspiratory efforts. And some patients who are having inspiratory efforts, we tolerate it if they're not too significant and the patients aren't too sick. The patients in particular where I think reverse triggering probably needs to be dealt with and addressed are in those that are much sicker, that are early in their disease with more severe ARDS, more severe hypoxemia, severely impaired mechanics, low compliance. And in those cases in particular, if the reverse triggering is resulting in breath stacking and these sort of larger tidal volumes that are being delivered. We see in some cases that reverse triggering can result in doubling of the tidal volume. And so if a patient is receiving 6 cc's or 7 cc's per kilogram of ideal body weight and they're having reverse triggering, they can be up to 12 cc's per kilogram with the delivered breaths. And in those cases in particular, I think it's important to try to limit the reverse triggering in those cases. So the approach of how to actually do it is oftentimes empiric, meaning that there's not a single one size fits all. And the reason why is because while we have grouped reverse triggering as a single entity, and we have called it this sort of neuromechanical coupling that is unmasked by deep sedation, the typical answer would be to lighten sedation, but that doesn't always work in some cases. In some cases, you see reverse triggering, or what looks like reverse triggering is probably actually occurring during this phase of lightening sedation when patients are actually waking up. So the answer is that in some cases, if it's very routine, regular reverse triggering, sort of the stereotyped pattern where you see like a consistent 1-to-1 and 2-to-1 ratio, that may be more of the typical form that is unmasked by deep levels of sedation, in which case you may actually lighten sedation in that case and actually get rid of it. Other forms are actually worsened by lightening sedation, and you may actually need to increase the sedation in order to get rid of it, if you really want to get rid of it. The other techniques are we think that potentially some of this is driven by the desire of the lungs for increased inflation. And so there's some great work by Takeshi Yoshida in Japan and some other folks in Brazil that are looking at actually using other ways of inflating the lung to satisfy the drive of the patient's needs. When the lung gets inflated, that stretch actually targets what's called the Herring-Breuer reflex, which is a reflex that almost satisfies the respiratory drive of the lung. And by increasing PEEP, by increasing tidal volumes, if it's safe to, you may be actually able to suppress some of the drive for reverse triggering in some cases as well. You can also play with your inspiratory and expiratory times as well to potentially take what is a reverse triggering, which is occurring for long enough and actually going through the refractory phase and the expiratory phase to actually trigger an additional stacked breath to actually only occur during the inspiratory phase. But that's a little bit harder to do because you may be limited in how long you can actually lengthen the inspiratory time in some cases. So I apologize that it's not a very satisfactory answer. The answer is that it's empiric, and having a routine practice of making small adjustments to the ventilator to increase the level of support, making adjustments to the respiratory rate. Sometimes if I increase it, I'm increasing the support, and I can suppress it a little bit. But sometimes actually you want to do the opposite, return the respiratory rate down a little bit, and you actually let the patient start to take control of the breathing and their own pacemaker take over, and then switch them to a pressure support mode eventually if they're well enough. So the true answer is probably it depends on the sickness of the patient, the type of dysynchrony, the type of reverse triggering they're having, as well as the level of support that they're already on. And in some cases, you may actually need to go back up on the sedation to help suppress it. In some cases, and in others, you might need be able to go down on the sedation level.
Right. So thank you, sir, for the detailed answer. Lovely. So then one question about till a few years back, we used to use deep sedation and knock off the patients, thinking that this was the best for the patient. When then obviously we realized this was leading to more delirium, more post-traumatic stress disorder. So, this seems a little counterintuitive that you're putting the patient to sleep, but in the long run, this is being deleterious. So what is and especially for midazolam we stopped using after this practically. So what is the mechanism, sir, leading to increased delirium and increased incidence of post-traumatic stress disorder when we use deep sedation?
Yeah, I think it's multifactorial. One of them is that sedation does not equal sleep, which I think is a misunderstanding still by a lot of clinicians. Um, when we use propofol and opiates, that doesn't result in typical sleep patterns on EEG monitoring. And sleep, as we know, is incredibly important for recovery for patients and for normal physiology. And so by suppressing typical sleep patterns for extended periods of time, we that may inadvertently cause some serious harms for patient, particularly with delirium and other issues. We also separate the typical circadian patterns from people with our mechanical ventilation strategies, which we know is also very important for um, uh, for um, uh, maintaining um, uh, typical physiology and normal patterns for patients as well. Um, and then the other ones are really probably related around duration of mechanical ventilation and the duration of support that's required, right? So if patients are on deeper levels of sedation, it takes longer to wean people off of it. There's more tolerance that people build up to the sedatives themselves. Um, and then people have additional issues around the total burden of sedative that's used, even after they're done with mechanical ventilation. They may have issues sort of weaning off of the opiates and everything that have been used. Um, and then there's even some really cool evidence that certain of the sedatives that we use actually may inadvertently worsen PTSD themselves directly. So propofol is an interesting one because we use it very commonly, and there's some really interesting functional MRI studies which show that propofol actually may worsen the neurologic sensation of pain, and so it's hard to measure this because these patients are deeply sedated, so they're not able to actually interact and tell us that they're in pain. But if you look at a functional MRI, that actually those areas of pain signaling actually may be further accentuated and light up more with propofol. And pain is one of the biggest things that are associated with PTSD in particular. And so we may be inadvertently, by using some agents like propofol, maybe worsening the sensation of pain and then thereby increasing the incidence of PTSD. And then, so the answer would be, well, maybe we should be using more benzodiazepines. And the answer there is probably not also, because we know benzodiazepines are, especially in more elderly patients, may be associated with delirium as well. So I think the long and the short of it is that you kind of feel like you're kind of caught between a rock and a hard place. None of your agents feel like they're great choices, which is why individualizing the choice of agent for the patient, the disease state, their age of the patient, et cetera, is probably what we need to do. But we still are not there at the point where we know enough from our research to actually prescribe really clear strategies for the individual patient yet. Um, but that's really where this is going, is balancing, a whiff of opiate, a whiff of propofol, a little Precedex, maybe a little ketamine, right? But we're not at that point yet where we can determine that. But ultimately, the goal is to really expedite lung recovery, preserve diaphragm function, get people extubated quickly, and then as best as possible, prevent them from having long-term side effects from delirium and PTSD and other negative consequences, which we think that sedation probably has a large contributing factor to.
Thank you, sir, for the answer. So then moving on to neuromuscular blockers. So there are no clear guidelines on how to, monitor the amount of neuromuscular blockers that we are giving. What kind of level, what kind of dose we should be using. Even the Roche trial, the ACURYSYS trial, they never monitor the depth of neuromuscular blockade. And obviously,
Yeah.
we don't want to give too much neuromuscular blockade. And we have peripheral nerve stimulation and all those things. So what can you tell us? Should we be monitoring the a neuromuscular blockade depth or what, sir? To optimize the levels of neuromuscular blockers.
Yeah, I think this is a question that also doesn't have a good answer yet, too. I'm not sure if you and your folks use train of four measuring skeletal muscle contractions in particular. we have moved away from that because the skeletal muscle response to neuromuscular blockade is quite different from the diaphragm. The diaphragm has a different onset of paralysis and actually will be unparalyzed faster too than skeletal muscle. So you may be incorrect when you're making assumptions based upon train of four measurements. Um, uh, the long and the short of it is I think that the best thing probably to do is to titrate to effect. And whether that's your just bedside assessment of whether the patient's synchronous on the ventilator or not is probably maybe as good as anything for assessing the direct effect of the neuromuscular blockade itself. Um, I think even more important though than that is in which patients do we still actually even apply it in, right? It's still very common to be used, but there's really not a good consensus about when and in whom we should still be using it, despite it being used still very commonly. Which is why I think we need further evidence to tell us about some of the dysynchrony. There's actually a really cool built-in study called the Red Rose trial, which was built into the Rose trial, which has not been completed yet, but looked at measures of synchrony and patient activity in the Rose trial, and actually with planned reanalysis based upon the level of dysynchrony that was present for the patient. To be frank, the method that we use for monitoring depth of paralytic, I don't think is generalizable to a wide audience. We have a site that is very comfortable using esophageal manometry, and so because of it, it allows us a window into the physiology, which I think is really great, but I don't think it's generalizable to the wide public. So when I was showing you that, I wasn't sort of suggesting that this is something that should be used across a wide population, but that this should be that this is just showing the potential benefit that could be used for a physiological approach.
Thank you, sir. Just a final question about the recent update on PATIS guidelines. So they have shown and recommended that melatonin may be used to reduce the incidence of delirium. So should we be using melatonin, and in what patients, what dose? So can you just enlighten us about that?
That's a good question. I don't know. I don't know the answer to that. So I don't have a recommendation on that. Maybe there are folks who have more information on that, but that's not something that I can give a clear answer for.
Great, sir. So thank you very much, Dr. Cassis, sir. It was wonderful, very enlightening. I loved it, and I'm sure the audience loved it. We had a wonderful audience. Thank you very much, sir. And thank the audience also.
Thank you very much. I appreciate the time today, and I know it's at nighttime there for you all, so I appreciate you guys joining in the evening, and I hope that you all have a good night. And thank you again for the time today. I really appreciate it.
Thank you very much. Thank you.
Bye bye.
Bye bye, sir. Good night.